He assured me we would have had a haircut for the meeting, but he just hasn't had the time. So without further ado, I'm going to ask Mervyn to speak to us about the ethics. And I mean, it's scheduled for an hour, but I don't think it'll take an hour. But Mervyn's going to share some of his thoughts. And I can think of no better person than to talk to us, and we're humbled by you, Mervyn. Thank you.
Thank you so very much, Barry. And once again, very gracious and humble thanks for the opportunity and the invitation. It's always a delight, and this is such a fabulous meeting. Everyone learns an absolute fortune from it. So just a short while ago, in fact, Barry had asked me if I would perhaps share a couple of words really on COVID-19 and the intensive care unit, looking at some ethics and some of the lessons that have been learnt. And these are my disclosures. And this is really what we will run through in the next short while. It by no means will cover the time frame that Barry has put down on the timetable and the agenda. And we're going to look at briefly a descriptive issue of what we're going to talk about. And then I want to touch on a couple of things that I think have been really relevant. Preparation, communication, issues pertaining to staff protection, dealing with this massive challenge, and also viewing it as an opportunity. Emphasizing simplicity, and something that we often forget in the complexities of things that evolve, and recognizing that we need to be flexible. I want to touch on something that I think is very close to my own heart, and that is what it means to be in this profession. And then look at the whole element of critical care, which is what this ethical element is addressing. Touch on what we really mean by difference, and then ultimately wrap up. So these are some of the words that were put together in a recent description relating to what's happened certainly in South Africa over the last 10 months and in the world from the beginning of the year. And these were the words that in fact I put into this commentary. It's been both taxing and tantalizing, and I guess that could be changed to tiring and terrific, eerie and enthusing, and maybe exhausting and exhilarating would be suitable terms. It's been intrusive and illuminating. We've learned a fortune, demanding and distinctive. And if I look back at the South African scenario now and what has gone on globally, in many instances it's been rewarding, but in fact it's been a time that has required us to reflect on many different things, including our own profession. And we've learned a fortune of lessons from it, human lessons, medical lessons, and lessons within the thrombosis and hemostasis world. When we put this background into the South African context, I think we were dealing up front with potentially something that may have been different. If we look at where we come from in the South African scenario, we really are a low middle income class country, and in many regions extremely resource limited, where there is no running water, where there is no piped oxygen in our hospital facility. There are also vast differences from what had been experienced previously, differences in diseases. We see tuberculosis, HIV, hypertension is endemic and hugely problematic in our populations. As a consequence, we see chronic cardiac disease, chronic renal disease. Diabetes is currently an explosion that is occurring not only in our country, but on the African continent. And then we see things like endemic hepatitis B, malnutrition on both ends of the spectrum, patients who are severely malnourished and wasting away, to those that are obese but effectively malnourished. And in fact, South Africa is the third or fourth most obese nation in the world. And we know that, in fact, turned out to be a massive risk factor. And then we see things like cigarette smoking on the rise, which we now know is certainly an exacerbating factor for more severe disease. So the South African background, a very real one. And for many of you who are listening to this, to put into context the country that we live in, we need to recognize that 55% of South Africans, in fact, live on under 30 Rand per day. For those who are joining us from outside, that is round about $2 per day, or 1.5 euro, or just over £1 British. And so that is the vast bulk of our population. Most of these individuals live in dwellings that might house anything up to 10 people in a single room. And 16 million South Africans travel every single day in minibus taxis that have been built to carry 7 to 10 people and sometimes 20 or more people. And so the elements of social distancing and potential infectivity, real challenges in the South African scenario. So what were some of the issues that I think were really relevant that we can in fact take out? And for me, the first was preparation. And in fact, South Africa had the gift of time, and in critical care, we certainly had the gift of time, which was round about 3 or 4 months following what was going on initially in China, then in Europe, the UK, the USA, and elsewhere. And during that time, it gave one an opportunity to recognize what we, in fact, may have to deal with. And being a referral center for viral hemorrhagic fevers, every year we see several cases of Crimean Congo hemorrhagic fever. In our particular hospital, we have seen Marburg virus disease, Ebola virus disease, Lassa fever, the Juno virus. And so we fairly geared from an infection prevention control issue based on prior experience in terms of what needed to be done. So as soon as we heard what was in fact going on in China, we in fact early on got a representative team of all the relevant role players, intensive care specialists, microbiologists, internal medicine people, and everyone who would potentially have had a role in making a plan so that way before we potentially had patients, we could have something in motion that would allow us to take forward this very big challenge and try and address it to the best of our ability. And in fact, after our first meeting, which occurred 3 to 4 months prior to things happening in our country, we had a working protocol. And many of you would be familiar with the fact that that protocol, in fact, was refined as we learned things along the way, and in fact, essentially adopted countrywide. But it emanated specifically in our unit on day one, following the initial meeting that we had with the relevant role players. The second important issue that I think cannot be overemphasized is that communication is paramount. And wherever there is a lack of communication, you will find that there's a breach in service delivery, human interaction, and all sorts of issues subsequently arise. And so in my mind, having thought about it and having been asked right at the outset, in fact, to consider this entity and in fact be the person who got everyone together and initiated in our hospital the elements, I felt it was absolutely essential as a component in every single interaction. And that should occur both in a COVID and a non-COVID setting. And the communication that I tried to engage and share and promulgate was that it should be engaging, constructive, polite, and always inclusive. And part of the reason for that was that when people started realizing what was going on around the globe and seeing pictures on Sky TV and elsewhere, there was enormous fear, panic, anxiety. And in fact, with our workforce, we essentially, many of them said, we don't want to be involved in this. This is not what we want to do. And how do you send unwilling soldiers to war? And so what I did in our unit, our small intensive care unit at that point in time, was begin a daily staff interaction. And when I say daily, that was setting aside one and a half hours approximately in the morning to 2 hours, and a similar issue in the evening so that night staff could be engaged with as well. And we addressed all of these issues openly with respect and tolerance, and it was always inclusive. Everyone had a voice. And when we talk healthcare workers, we're talking about porters, the security people, the administration staff, the nursing staff, the doctors, the allied health professionals like physiotherapists, dietitians, and so on. And everyone met with appropriate social distancing. And we went through this. And as a consequence, we were able to address many of the fears, the anxiety, the panic, address any issues that in fact supervened, and in fact use it as a forum to really tell people how important they were and how we appreciated what they in fact were doing. It also allowed us, once we'd worked through elements that may have been problematic, to then make decisive decisions because everyone had been informed and they were very easy to implement. And in fact, the staff felt backed and appreciated. And as a consequence, they really went about things with passion and purpose. It spilt over to other disciplines, and there was cohesion and collaboration and collective efforts. And from initially addressing an issue where we potentially may not have had a workforce, we were having people who were volunteering for extra work. And so it really was remarkable, and communication in any of these contexts cannot be overemphasized. We didn't forget the patients and their families, because what I found was going on, speaking to colleagues outside and abroad and elsewhere who'd been through the process, was that many families were left in the dark and were not sure what was happening, particularly in the ICU scenario with their loved ones, and video calls for those that wanted to see what was going on right at the cutting face. And outside of that, we would make sure that every single day there was communication that was shared with families for patients, for example, who may have been ventilated. Staff protection was absolutely key, and in fact, a non-negotiable issue. And right at the outset, and perhaps related to some of the fear, panic, anxiety, and so on, we did have several staff members who did get infected, and some of them seriously ill. And the bottom picture here with this healthcare worker with a mask on is in fact a compilation made together and put together of thousands of names with different colors making up the image of our dear colleagues who in fact succumbed to this disease. And at the outset, we had some patients and colleagues and healthcare workers, one or two of whom were from my own unit, who landed up in the ICU severely ill, and we're talking about saturations of 30%. That was our first colleague, who was one of our unit managers, an excellent ICU nurse. And in fact, we salvaged this patient after 3 weeks in the ICU. And in fact, today he's actually working in the unit. And so very soon, and I was adamant that staff protection was absolutely key. There were guidelines that were put out, national guidelines, WHO guidelines, other international guidelines. But when one went through these, we realized that perhaps there was something missing, particularly when it pertained to personal protective equipment. And you'll see these pictures on the right-hand side of the screen of our staff members whilst we were undergoing training. And when we looked at frontline workers, one of the things that we noted, even in the WHO guidelines, that was missing was that there was not adequate head protection. There was not adequate foot and shoe protection. And in fact, if one went through the literature, there were cases of people having been contaminated from having touched their shoes or taking them off. And why should potentially a droplet stroke aerosolized disease avoid your head or your face? And so we felt absolutely adamantly about the fact that we had to have head protection and shoe protection. We initiated this. It became a non-negotiable issue. We started our own training in our unit, and very soon everyone was joining us, including some of the people who were putting together national guidelines. And in fact, this particular way of addressing things was widely adopted. These sort of training sessions gave us an opportunity to reinforce exemplary infection prevention control measures, and we faced enormous challenges, bearing in mind that working in a state, an academic institution, in a resource-limited setting was a real problem. We sometimes didn't have PPE, and we had to really push very hard to make sure not only that we had PPE, but that our real frontline workers were adequately protected. And with the protective measures, we in fact advocated. And I know I was involved with in a European webinar where I was asked to engage with one of the WHO advisors, and these were things they had not actually considered. Following that, we had very, very few healthcare infections amongst our colleagues. Many of the challenges outside of just having adequate PPE included things like not even having soap at some stages. And so we really faced massive challenges that many other resource-limited settings also faced. With every challenge comes opportunity. And I think this is one of the most important issues for all of us to recognize, because it doesn't matter where we practice. What this pandemic has told us is that even if you're in a resource-rich environment, people were inadequately prepared. Amongst the highest mortalities, and there are many factors for that, were many high-income class countries. But this, I think, is of enormous relevance in resource-limited areas and settings and countries. And I want to re-emphasize that 87% of the world's population live in such areas. 87% of the world's population live in resource-limited countries. And so, having thought about that during our preparation, for me, it was fairly evident early on that what we needed to do, bearing in mind the reality of the South African scenario, and to put that into context and focus just a little on the critical care scenario. If we were looking at data that was coming through from elsewhere in the world, where around about 20% of infected people would require hospitalization, and around about 5% of those may progress to getting more severe illness requiring critical care, in a population of 60 million people, we would be absolutely overwhelmed, not just in the hospital, but critical care facilities, which had a premium in South Africa, would really be a problem. We have round about 70 to 80 trained intensive care specialists in South Africa, but in terms of those who are actually in current practice, full-time, round about 35 to 45. For a country of 60 million people. The best audit of the number of ICU stroke high care beds was done by the Critical Care Society some years back. And that suggested, realistically, we had about 4,500 ICU and high care beds in both the academic stroke state sector as well as the private sector. And in the state stroke academic sector, which provides care to 84% of 60 million people, that equated to 1,100 beds, which is really a real issue, and bearing in mind that you have around about 40 people in critical care to deal with that. And what was being advocated was the building of field hospitals and field ICUs, and very early on in my hospital, recognizing the issues, it would have, in my opinion, not been absolutely ideal to go and create field ICUs, because who was going to man them? Who was going to manage them? How was one going to deal adequately with it? And where were we going to get the human resources? And so I engaged with some social responsibility partners and felt that what we should be doing, and certainly I offered our hospital, which was a designated COVID referral center, and in fact, one of the major COVID referral centers in the entire province, as a pilot site. And I said, let us look for areas in our hospital that we can expand our ICU capacity. We did this with social responsibility partners, and within 6 weeks, we had more than doubled our ICU capacity. And that included finding areas in the hospital, moving out various other disciplines to other areas. There was a lot of great engagement there. The funding came through, we got the relevant equipment, we did absolutely everything, even engaged with the construction people who did the refurbishment. We got the beds, we got equipment, and we more than doubled our capacity, which gave us some sort of degree of reassurance that whatever we might have to face, we would be better off than when we were in the pre-existing scenario. And in fact, as a consequence of that, we were able to facilitate similar exercises elsewhere in the country. So as a consequence, at Livingston Hospital in Port Elizabeth, they took exactly our model. We got the social responsibility partners to engage with them, and they expanded their facility. At King Edward, the 8th Hospital in KwaZulu-Natal, which required definitive expansion. The same thing has happened at Dr. George Macquarie Hospital. A new 20-bed facility, in fact, came about. And so what this effectively, in my opinion, would also have done was that beyond COVID, and there will be a beyond COVID scenario, is that these facilities will remain. And that is what I mean by the opportunity. Opportunity not only to facilitate care during the crisis, but the opportunity to provide care for many thousands of individuals beyond COVID who will benefit from these facilities, which would never have occurred because this was done with social responsibility partners. Once we'd got everything sorted out, we went to the authorities and got them to sign it off. And there was no real problem because it just would not have been feasible in any other context. And so what this has done for our hospitals, probably put forward critical care a decade to 2 decades or even more. At the same time, it's all very well having expanded facilities, you've got to staff it. And so we recognized this early on, and we started a nursing upskill project with often basic nurses, nursing associates, nurses from old-aged homes. And we put together and developed a 2-week course together with the university nursing department, and many of us were involved in hands-on teaching. And then we got the nursing staff into the facilities, and so they'd had a basic background, they started learning on the job as well. And now, whilst COVID in fact has come down a little bit, although we are seeing a little bit of an increase, we are able to actually offer care to many non-COVID patients who would not have had that opportunity. We also initiated a project to look at acquiring some ventilators, and this was early on, and we looked at ventilators that would not necessarily be fancy, that could be used even in our cluster hospitals and regional hospitals, where training with these particular devices could take place over a period of half an hour to 1 hour. And the device that we chose after a lot of research is a 1 kilogram portable device that can run off an oxygen cylinder that has battery backup for up to 24 hours, and that has been shown to be robust for up to 36,000 hours of continuous use. And in fact, trying to acquire this particular make of ventilator was not easy, but we managed to get 300 of them, and those are now being distributed and have been around country and will serve a purpose not only in the COVID setting in regional hospitals where these things could not have happened otherwise, but will serve a purpose way and beyond for many, many years. At the same time, we repurposed CPAP devices. Many of you would remember so-called wall CPAP. And this picture, the right bottom picture, is a repurposed CPAP device manufactured in South Africa and costing the equivalent of 16 to 1800 Rand, which is 50-fold less than a high-flow nasal oxygen machine and 200 to 300-fold less than a conventional ICU ventilator. It is extremely simple to use with a PEEP valve and with an oxygen a dial that dials in the amount of oxygen with PEEP, with a face mask that fits over a patient and gets plugged into an oxygen socket. And so this potentially can change the trajectory of this, and has. It was extremely useful. And that was developed in South Africa with collaboration with us, and is being rolled out again around country, and will have impact for many, many years to come, and almost certainly will save thousands of lives. And so these elements, in the context of this massive challenge in a resource-limited setting, probably will result in benefit for years to come for many, many patients. This, for example, is a picture I took just yesterday of a COVID patient being nursed in our new facility. It was almost unheard of to have had this. And in fact, over the context of time, and in our hospital at one point in time, we had 400 odd patients with a packed facility, and we accommodated literally everyone. So it was really something that I think was enormously useful. Another very important lesson was to keep things simple. And I think over the years, many of you may have heard me go on about the adage that I still like sharing, teaching in our unit, and that is to maintain simplicity, pragmatism, and adherence to basic principles. And if you do the simple things well, by and large, most of the time, you're going to get it right. And in a setting like ours, that involves the use of clinically resource-limited countries. Unfortunately, it's whittling around the globe. And just over the last 18 months, we've in fact put together, I think, the first textbook of clinical skills in adult critically ill patients. And when I last looked, just the downloads, which have been made available, close to 50,000. And that's just for intensive care people and other people. And I think the number of books sold is way and beyond that. And just to share with you, I haven't had a single royalty for that, but they were wonderful people who committed to that. And I was just one of the people who got involved in the idea. What that brings me to is that this clinical acumen helped us. We didn't go around and do CT scans on all of our patients. We relied on clinical acumen, basic skills, chest radiographs that told us pretty much everything that any CT scan could tell us. And so it brings to the fore the issue of poor. Being poor doesn't mean poor care. Sound practice with excellent quality of care is absolutely feasible and possible, and excellence is achievable even in the face of adversity. What were some of the other elements when we look at this simplicity? And we were faced with the scenario, and we were told, just get on and do more with less. That's exactly what we were told, and we tried to stretch things as far as it would go. In fact, at one point in time in the ICU, with these very committed, wonderful staff, there was nursing to the extent of one nurse for 4 ventilated patients. Many of us came in and we, in fact, ourselves nursed. I did several 11 until 7 in the morning nursing duties as well. And what we realized, this is a wonderful statement that many people throw out, do more with less. But what I learned in the context of the last several months is it's great to do more with less, provided you don't do less for more. And I think that's a very important lesson for all of us to take on. You can stretch it, but there's a threshold beyond which you in fact may compromise patient care. And so we relied a lot on creativity and innovation, and that included with therapy and with the ethics that we had to deal with in a resource-limited setting where we were faced with massive sort of challenges. And right at the outset, one of the things that we thought we might have to do in terms of triage, because There was a real concern that we would be overwhelmed. Patients were just flooding in. We introduced and went back to something that, in fact, I was asked to put together some years ago, looking at ethical principles in terms of how we should be triaging without making it too complex. And at the end of the day, really what we felt was it would depend on the patient profile as well as unit capacity. And that was shared with many other people elsewhere. And it's something that we've had to face for years, year in and year out, and so have many other individuals. And the R's really relate to the following. Is there a rationale for the patient to come to ICU? Is it reasonable for them to come? Is it responsible for us to do so? And is it realistic, bearing in mind our infrastructure? And if the answer to all of those R's, the rationale, reasonable, responsible, and realistic, is yes, you have made the right decision. So there are 5 R's. And if you have some yeses and some nos, no one should ever be compromised, because then you go back, reassess, reevaluate, and reconsider. And we did that with everyone. And no one was compromised. We didn't have these stringent exclusion criteria that were prevalent elsewhere. And in fact, we saved many patients who may well have been turned away and in fact succumbed. Corticosteroids, a very interesting issue. We know from the recovery trial that this, in fact, in the ICU scenario, saves around about 35% of patients, and as many as 20 to 25% of patients in the non-ICU scenario who require hospitalization and are hospital dependent. And right at the outset, with our first cases, which was 3 to 4 months before the recovery trial, we were giving corticosteroids. And you might say, well, is that good science? What did you base that on? And we based it on our own work with varicella pneumonia, which is in fact an airborne type of pneumonic viral infection. And many years before, we described the enormous benefit in critically ill patients of corticosteroids in severe life-threatening varicella pneumonia. That in fact changed world practice and has saved many hundreds to thousands of lives around the world. So we had very little doubt. And in fact, the corticosteroids came from our unit and in fact emanated, for those who chose to adopt it, around country, including the dose, because there were people who were promulgating high dose. We gave a very moderate dose, almost exactly the same as came out in the recovery study. And when our colleagues in other areas of the country were saying our mortalities are in excess of 80, 90, 100%, we were saying, but our mortalities are less than half that. And almost certainly the corticosteroids had an impact. We also realized that very simple initiatives would make a massive difference. So very early on, in my mind, when we moved into our new ICU and when we were looking at it, one of the things I had suggested was we must have big, wide windows. We don't have negative pressure facilities. We don't have fancy extraction devices to remove aerosolized virus. But if you open the windows, which is what we did, you get 6 to 12 air exchanges per hour, and in some instances up to 20, better than any negative pressure facility, better than many extraction devices, the most expensive ones. And in fact, I shared that early on in a European webinar. And in fact, that got enormous airing, if I can use the term, and in fact, saved the infectivity of many healthcare workers and other patients. A lot was said about proning patients, turning patients in the awake state and in the ventilated state, for example, onto their tummies or onto their sides to improve oxygenation. And it soon struck me that this proning issue was quite difficult because you were taking very, very sick patients, even when they were awake and not ventilated, and asking them to turn themselves onto their tummies and to turn themselves onto their sides with the aim of trying to improve oxygenation by improving the ability of the lungs to expand, particularly the basal regions of the lung. And just thinking about it one day with, in fact, one of our own staff members, the very member I alluded to earlier on, who came into our unit with saturations of 30% on 100% oxygen. And it would have been impossible. And I said, let's sit him. And when he's a little stronger, let's stand him. And in fact, it was brilliant, because that's the best way to expand your lungs. Why would you want to necessarily turn them on their tummy and have something on their anterior chest wall to allow expansion of the lungs when you can do it gravitationally? And so I think that was another fabulous element that allowed us to save many patients and avoid having to actually ventilate them. When high-flow nasal oxygen came to the fore, many people were afraid globally, as well as in our own country, that aerosolization and risks to other patients as well as ourselves would be an issue. And we were amongst the first people to say, let's just put a surgical mask over the interface. And we did that. And in fact, many people have adopted that policy globally. In fact, I shared it in many other resource-limited settings. And we only had 6 high-flow machines, and we managed the entire massive surge with 6 machines. We also try to maintain a service for our non-COVID-19 patients, because I think one of the real issues that has been forgotten, and in fact in the preceding talk, in Derek Roll's talk, he said, well, you know, many people are dying from atherosclerotic disease far more than COVID-19 patients, and patients awaiting cancer surgery, patients with other diseases, patients with tuberculosis and complications, as we see in this country, and HIV. We try to accommodate all of them. The expanded facility made a massive, massive difference. Another very important thing that I think was really relevant right at the outset, we recognized that one has to be flexible. Nothing was cast in stone. We in fact had living protocols and that were adjusted all the time. We followed trends, continuously engaged with various authorities, people that we knew and groups. And I was fortunate enough to currently be involved as the chair of the Global Intensive Care Working Group of the European Society of Intensive Care Medicine. So every single day I was getting hold of many of the wonderful people across the globe who were involved with this and gleaning their insights so we could introduce it and try and optimize what we already had. And then we went back and did some objective introspection and reviewed everything and adopted many of these issues and put them into our management protocols accordingly. So for example, right at the outset, many of you would be familiar with the issue that people said, don't ventilate patients. If you ventilate them, in fact, you're going to die. Data from New York said that 88% of people who were ventilated mechanically, invasively, in fact, succumbed. And we essentially at the outset tried to avoid that, and we used rebreathing polymasks with gravitational dependency, as I mentioned in our setting, got away with it. We then moved to high-flow nasal oxygen and CPAP devices, which we weren't afraid to use, and soon realized if you pushed patients on those, in fact, and then had to ventilate them, the outcomes were poorer. So we very soon recognized and are now extremely comfortable with knowing when to intervene, how to intervene, and we are not afraid of ventilation, and we are salvaging the vast bulk of our patients who land up with mechanical ventilation. And so the simplicity and the flexibility certainly appear to have favorably impacted on our outcomes. And looking at some of the global data for ARDS, and patients have been ventilated for ARDS, and the global outcomes, which are in the region of about 59% in a recent paper, from all the cumulative data that's been shared, I can tell you that our mortalities are less. One of the issues that struck me working every day and every night, and willingly doing so, is that we work in a wonderful, wonderful profession. And I think I was reminded every single day and reminded many of the others, and that's why I put in this little graphic. It's something very close to my heart and a profession that I actually love, is that it's a real privilege to be in this profession. And the COVID-19 pandemic has brought that to the fore, but every day we should be reminded with the non-COVID-19 patients we also see. It's a real privilege to be in this profession and try to make some sort of impact in the lives of people who often don't have a choice. What about critical care? So when Barry asked me, he said, can you give some insights into intensive care and some of the ethics and some of the issues that have pertained? And intensive care is the term used in some scenarios and critical care in others. But I think what the COVID-19 pandemic has in fact done is bring to the fore the relevance of critical care, hugely relevant in resource-limited countries, incredibly relevant as well in high-income countries, an often neglected issue. And what we now realize is that you cannot practice medicine without having critical care in any large hospital scenario. It is just not feasible. Just a week ago, there was a 5-year feedback in our university amongst all the disciplines, and every discipline gave feedback. And I was asked to give some feedback for critical care. And what I was able to do from every discipline is point out that every discipline, albeit psychiatry, albeit bioethics, be it internal medicine, surgery, and all the different disciplines there, and so on, obstetrics, if you have complex issues, you cannot manage them without critical care. And so I think COVID-19, from a pure perspective of critical care, has been one of the best things that could have happened. In my own institution, we do not have a single dedicated post, yet we managed more than 20 all patients that came into this hospital with less than a handful of people, medical people. And as I mentioned, we had the nursing upskills and some wonderful physiotherapists and administrators and others who got involved. And so this terminology that I put down and in fact recently put into text is that in our setting, so many have benefited from just a few who have ultimately given so much. And I think that recognition is coming through because in the last few days, the Society of Critical Care Medicine in the US has mentioned that critical care human resources, in fact, are exceedingly scarce. And the people who've been involved in this effectively have given so much that there is no more to actually give. And so the resource is becoming a really scarce entity. And so I really want to just reach out to all the courageous champions in this field and say, well done, acknowledge them, and give the kudos that they deserve. It's great to chat about critical care. And I think in my own scenario, what has happened with the partnerships and so on is that we've advanced critical care probably in this province and maybe hopefully in the country, because tomorrow I now have an engagement with the authorities who are going to specifically be looking at this. And so critical care, very important component in healthcare delivery. But I think I like to look at critical care and just use the terminology within it. And it's the following: it's critical to actually care. And I think it's got to be done in the spirit of Ubuntu, which is a wonderful South African philosophy. And I think the sentiments put forward by Desmond Tutu exemplify it, and I'll take you through it in a moment. But really what we are talking about when we alluding to Ubuntu is being compassionate and humane to patients and to our colleagues and staff across the spectrum. And Desmond Tutu, that Nobel Prize laureate, really put and encapsulated it in a couple of sentences. You know when Ubuntu is there, and it is obvious when it is absent. It has to do what it means to be truly human, to know that you are bound up with others in the bundle of life. And I think an enormous amount of Ubuntu was recognized, and we've certainly tried to share it in the critical care scenario. And so it brings me to a picture that really touched me enormously, and in fact brought a tear to my own eye, and we in fact tried to emulate this. And this was a patient who had COVID-19 disease, who landed up in an ICU, in which a decision was made that the patient would not be offered more invasive or aggressive intervention. And the patient, in fact, requested to be taken outside to see a sunset, as the sun set on his life. And so it was a really impactful issue. And I think when we talk about the fact that it's critical to care, and that great South African term and philosophy, Ubuntu, these are the elements that need to resonate with all of us. Difference is a term and a cliche that is bandied about very, very frequently. But I think when the term is used with integrity and credibility in the context that we are wanting to share it, it is possible to make a difference, even in the face of adversity, and absolutely nothing is impossible. I think if we take this term again that people throw out, nothing is impossible, and just turn it around with a little bit of work, with a little bit of effort, with a little bit of talent, impossible can soon become nothing. And so as I often end off, when we talk about South Africa and where we have people who may be joining us from abroad, but in everyday life, we were all fortunate to be in a country and to have exposure to a wonderful human being whom, as I've said, when history is written, will go down again and again, in my opinion, as the greatest statesman who did live. And he taught us about how important it was and how possible it is to overcome adversity, to address obstacles, and to deal with things that sometimes appear impossible. And for today, I'm going to use one of his quotations. I've used many over the years, but one that resonates with me in this context. It is in your hands to make a difference. And the end of the sentence is completed as follows: to make this world a better place for all who live in it. And some of these principles and some of these ethics, I hope, could go a long way in COVID-19 and in other issues to make that true difference. You'll see the picture below. In fact, is a beautiful arch in November 2020, of largely purple as well as green. And this arch is the road leading up to the hospital in which I work and Professor Jacobson works. And many of the people who are on this webinar today, and many of the people who may be tuned in, work. And this road leads, hopefully, to a beacon of hope, a beacon of light. Because if we have just a little bit of light in the most arduous scenario, where there's a lot of darkness, and in critical care, last year I shared with you that very impactful, emotively driven paper in the Lancet that in fact described critical care in resource limited settings as dying in the dark. It gives us that little bit of light. And if we have light, we have hope. And if we have hope, we can in fact move forward. And so through this purple, beautiful purple arch that makes the city that we all work in, for those of us that work in the city and on travels to the hospital, so beautiful for us every day. Adjacent to the hospital, and also where there are multiple jacaranda trees in full bloom at the moment, is a school. And that school, in fact, was closed for a portion of the COVID-19 pandemic. And I passed it every day and every night. And I always looked at the school because it impacted on me. What's happening? What is happening in this world? These poor children, education has been stopped. Elements in our lives have changed. And an entity came out from the very school that I think I'd like to finish off with. And it is a couple of minutes, but I think it is something that probably puts into perspective everything that has been discussed this morning and everything that allows us to continue to practice in this wonderful profession, to give others an opportunity of themselves, having an opportunity in life. And this is a song and a compilation put together by a wonderful choir, the school, and many South Africans would recognize some of the singers in this choir. And it is about a song that relates to rejoicing in the joy of life, the very essence of Ubuntu and the very essence of what societies like this wonderful society try and confer to people out there, and what the wonderful colleagues that have been on this webinar today themselves do. And that is trying to offer people life so that they can rejoice in the joy of it. And it's a compilation, something that was penned by Leonard Cohen many years ago and has been covered hundreds of times in many different languages. But the message is universal. I've heard it in many different languages, in fact, relatively recently in Zulu, and it once again moved me so emotively. I had to go back, and I've probably listened to this particular clip many hundreds of times, and I'm still moved from it. So it really behoves me just to thank the Society, Barry, for all the great work that you've put into this, for this marvelous webinar today, for our wonderful colleagues, for all the courageous healthcare workers around the globe who effectively with Ubuntu have been practicing this beautiful profession to try and give people an opportunity to themselves have some joy in their lives. Thank you with gracious thanks and a humble appreciation.
I heard there was a secret chord that David played and it pleased the Lord, but you don't really care for music, do ya? Well, it goes like this: the fourth, the fifth, the minor fall, and the major lift. The baffled king composing hallelujah.
School closed.
Hallelujah. 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 Your faith was strong, but you needed proof. You saw her bathing on the roof, her beauty and the moonlight overthrew you. She tied you to her kitchen chair. She broke your throne and she cut your hair. And from your lips she drew them hallelujah.
our hospital.
It's not a sign that you hear at night. It's not somebody who's seen the light. It's a cold and it's a broken
It's
Thank you,
why
Merv. Once again, thank you very much for a seminal talk that leaves us all really very moved.